Beating the waiting list backlog. My name is Tony Stakeover, and I'm a medical doctor and Director of Innovations at Cambridge Medical Academy. Today we will present to you two projects which we have been working on. Both are newly completed, Track Know and Backlog. And I would like to thank our audience for joining us today. We're hoping for a very interactive session. At the end, we will be discussing some questions. So, Track Know is a European project which deals with big data for mobility tracking in urban areas. It has been going on for 3 years, and we've been working on it, a group of 14 partners from 9 European countries. The coordinator is Inlicom Systems, and the main task of this project has been to develop new software tools that increase the efficiency of big data, but then these tools are put into different pilot domains. In our project, these were transport, mobility, insurance, and healthcare. And the commonality between them is that the system analyzes mobility across a geographical area. And that's where the business intelligence is about for those three different domains: for transport fleets, for electric cars, and for patient bookings in our case. So our health pilot in Track and Know has focused on patient bookings, patient travel, and attendances to clinics across our geographical area of PAPWORTH Hospital Respiratory Clinic. Now, the Backlog project is a small project which started 6 months ago as a result of an Innovate UK call to help the COVID crisis with various business-led innovations in different domains. We were happy to get the grant out of 8,600 applications. We were some of the lucky projects with our idea, and it's only for UK partners. It's an Innovate UK project, and we are the leader here at Cambridge Medical Academy, are the leader in this project. Now, the concept, why am I presenting them together, is because the concept of backlog is a natural continuation of the work which we did in Track and Know, and it focuses on the development of additional tools that help the geographical intelligence and the waiting list clearance. It also visualizes waiting lists and different options how to clear the waiting list and estimates the most efficient use of resources. So I hope you will enjoy the explanations which I'm going to give you before we demonstrate each project. Now, let me start with Track and Know. Track and Know, the pilot partner in Track and Know is PAPWORTH Hospital Respiratory Sleep Services. This department is one of the largest departments that provides management for diagnosis and management for obstructive sleep apnea. They have over 12,000 obstructive sleep apnea patients on treatment. PAPWORTH do more than 10,000 oximetry tests per year, and the whole area of Cambridgeshire and around is covered by 21 facilities supported by this service. The problem, however, is that we are finding that patients do travel long distances to pick up a test, and that the area is not covered very well in terms of demand and where the patients are. So there is suboptimal access to the service, which we want to improve. And we've also had a problem with no-show rates increasing, which is a waste of resource. And especially in the current circumstances with the waiting list being bigger and bigger, this is becoming even a more serious problem. Now, we don't have, normally in normal life, we don't have tools to analyze the data in the way which will give us a geographical business intelligence. Why is the problem so important, and why do we want to find all the patients? Because obstructive sleep apnea is a very serious issue. It's a condition which causes great public health concern. It rises also with increasing obesity, and it causes serious health problems. So therefore, if you treat it, you can avoid these problems, and that's why it is so important to find those sufferers where they are, to diagnose them and put them on treatment. So this is the reason why we're going on geographical intelligence, to look for our patients and how do we serve them better. Therefore, the project tries to understand the current operations. These are the aims. To understand the current demand within the service, where are the patients, where are our clinics, and to propose new allocation methods, how to cover them better. And therefore, we've also, in relation to this, we've also developed several KPIs that we would like to use to measure the outputs of the proposed measures, which is a reduction of travel, cost efficiency gains, meaning seeing more patients with the same number of facilities or lower number even of facilities, reduction of the no-show rate, and because we are environment friendly, we also want to associate this with reduction of CO2 output. So at the moment, what's there at the moment to give us in healthcare geolocation supported service intelligence? Well, in day-to-day healthcare, there isn't a lot. In fact, it's not really practiced. Where we see, we've been seeing more and more over the last recent years, is emergency and disaster medicine. We're using geolocation intelligence for resource visibility, for situational awareness, for fleet management of ambulances. And in public health, we're also using geointelligence for population health maps and epidemiological surveillance, as we've recently also seen with the COVID, all these maps. However, in normal day-to-day healthcare, it's not really being used. And that's why PAPWORTH's business case to want to audit the service and improve it is quite representative for the gaps and needs across the entire NHS, and in fact you could see all across Europe. So the current situation for intelligence is that we're using technology, being the hospital IT system. The referrals and the bookings for the patients are more or less centrally managed nowadays. And really the key aspect, the key reason for the bookings is to meet the waiting list targets. So the geographic proximity is less of a factor. It's not being considered that much, but it should be. So there are no analytics of the bookings at the moment that we have across the geographical area, no analytics of geographical access, the non-attendances, and overall the demands of the service where it should be deployed. We have specifically used the Track and Know project to ask for tools to audit, to help us audit the service and to provide some decision support, what we should do, what is the most effective deployment of services across the area. Looking at the market, there aren't also many publications or any tools that would give that sort of business intelligence in the context that we need. And that is why we have been extremely fortunate to be part of the Track and Know project and be able to use a very innovative platform which allows us to aggregate data that we would normally not be able to analyze together. So let me just show you briefly what the data are about. We have data that come out of the hospital system. They're all de-identified and protected. So we have a set of appointment data, a set of medical data, meaning medical related to medical risks and measurements of the patients. They're also protected. And then we put them together with demographic data, population risk data, and other interesting data like weather, traffic, points of interest, to find out if there are any alternative facilities that we could use for service deployment. And all of these data are processed by the Track and Know platform, some online and some offline by the tools. Here is just another view of the appointment data and the medical data. This is what's kind of going into the database, and there are quite a lot of number of tests that we've provided for over a 5-year period of the service. The data also include the attendances and the non-attendances, which is important because these are aspects that we have been analyzing. This is what the platform pipeline looks like. You can see different tools being involved along different pathways, and I will show you a little bit more about what questions we are asking this platform, either the whole platform to run those questions or just separate tools to answer those questions. And you can see also at which points the KPIs can be extracted. At the end of the processing, the results come out in a dashboard, and we will show you in a brief demo what the dashboard actually shows to the user at the end of the day, because that's the most important thing. Here are the KPIs again. Who is the user? You're going to ask. Well, the user for now is the service manager. Could be a doctor, director of the service, could be a funding manager, but overall it's a service manager, and the service manager needs business intelligence to better understand the service and to optimize it. So this platform offers two types of scenarios. One is analytical scenarios. These ones give us new insights about how the service functions and what are the possible factors impacting. And then obviously you have also simulation scenarios once you have gained insights to say, what would happen if I did this? And this is what we're going to show you. Now, this is an overview of another view of what our data looked like. We have various clinics, which are the main hospital, outreach, GPs, and an additional clinic. And these clinics, over the 5 years of data evaluation, they've been working in different constellations. And what we have done is run analysis of the different batches. So we've taken different batches where we had different service constellations, and we've run an analysis to compare them and see what's coming out. And you will be interested to see, I'm not going to go through the whole thing, but you will be interested to see that since this analysis started, which is 5 years, the no-show percentage has increased, which is a real concern for the NHS and for the funders. So this is something where we need to take further measures. Excuse me. So we've also been able to look at the average travel and also how many patients are seen per day. Let me show you a couple of outputs before we run the small demo videos. When we are asking, so when the service manager asks, where are my patients and where are my facilities, please compare them. The obvious result is that there is a lack of provision in the east and the north, and there is over provision in the center. I mean, that's not a big surprise, but then it becomes a bit more interesting. When I ask what's been the average travel distance for the period, so for every patient, the average travel distance, we can see that there have been too many patients, or most patients have been scheduled at PAPWORTH at the central side, and they've been asked to travel quite excessive distances, which I'll show you in the next slide. So some patients have been allocated appointments across 3 or 4 facilities, so they've not really been to the nearest facility. And it is obvious that some patients need to come to the central site, but there are also a lot of appointments where they don't need to come to the central site. And if you look here at how many patients traveled more than X amount of kilometers, the red dots show you how many. So here, for example, all the red dots have traveled more than 60 kilometers in order to have an appointment. And you will also see that there are quite a lot of red dots in patients, postcodes, aggregated. They've traveled more than 120 kilometers. So this is significant travel distance that might be a factor for non-attendances. We don't know. So we kept asking the system to tell us what else can we see. So for now, we know there is a lot of distance, a lot of travel there. Then we used another tool within the platform to visualize the attendances and the non-attendances to the different centers. So those blue dots are different centers. The red lines are the non-attendances, and the yellow ones are the attendances, simply speaking. What we could see, however, here is that there wasn't any apparent relation between the no-show and the distance they traveled, which surprised us a little bit, but you know, that's why you're doing analytics. we continued looking, maybe if you break down, maybe you will find something. And we did some sub-analysis. So we did find some spatial patterns. For example, there are some clinics in the Northeast that have a larger proportion of no-shows. But then when we put this in context with other factors, historical and regional factors, we actually found that it's not the distance, that it isn't the difference in the distance which made those facilities have more no-shows. It have been other reasons. And again, this is a take-home message for the funder and for the service provider to look deeper and search for the real reasons. So we can conclude that there hasn't been any, surprisingly, there hasn't been any relationship between travel distance and the no-shows. So then, being curious, we thought, well, are they related to weather or seasons? Because we suspected that when the weather is bad, the patients may not want to travel. And we've plotted the appointments against the weather open data of the weather that are available publicly. And we were very surprised to find out that the weather had such an impact that in good weather, patients wouldn't come, as opposed to our expectations that in bad weather they wouldn't come. This was surprising. So patients prefer to do other activities than coming to an OSA appointment. And when you look also at the holiday seasons, we found that in July and in August, patients are attending less. But again, this is an important message for our service because in summer we struggle anyway with staff coverage. And maybe the lesson here is, the lesson learned is that we shouldn't be booking that many patients anyway. And we need to consider how to manage this obvious problem with the staff shortage and patients not coming in summer so much. We've also looked at other aspects. I'm not going to go into this now because we're showing you later a few points of interest, but in relation to the ideas that have been floating for some time, but just lately they've become very important in view of the COVID, is looking for alternative facilities. Can you find other points of interest in the area that could serve as alternative facilities? We've run such analysis as well because you could use pharmacies, GP practices, even shopping centers in order to deploy the service where it's really needed. Now, moving over to the issue of where is the demand, we weren't satisfied with the existing map, which is a great achievement that we recognize, but now we have more data and now we felt let's do another map. So we've used our tools to generate additional maps, also with the help of an outside partner from University of Bedfordshire, for which we're very grateful to the public health partners. But what we see here is different colors, which represent, one is a map based on the risk factors. So where are my patients positioned that have the most severe risk factors? And now you understand why we needed the medical data set and why we needed the demographic data in order to be able to find those densities. And another map represents the demand from the perspective of the population densities. Why do we need different risk maps? Well, because sometimes for certain decisions you want to base the positioning based on risk, but in other cases you might want to decide based on population density, and you could also overlay maps to find out where is the biggest demand. So this is the reason why we've generated additional maps that we couldn't have done otherwise. We have one more map to show you. That's a very interesting one. We have looked at deprivation. Using demographic factors, we've generated a deprivation map. And what came out there was that in the deprived areas, which are the more orange areas, from there, the hospital receives proportionally less referrals. So less patients from the deprived area get referred for OSA assessment. And interestingly, those ones that get referred, they get more no-shows. So these are real problematic areas that we would need to address, maybe with alternative solutions. We need to come up with some ideas and propositions. How can we serve those areas better? Because clearly there is a problem. Now I'm showing you a few screenshots, but I'll play the video in a moment. This is what our dashboard looks like, and on the dashboard we've selected to have two map views, which would allow us to compare two different scenarios and also look at how things would change. So that's why we have two map views. Those maps, they have different buttons where you can show hospital demand, census demand, facilities, things like this. And down here, I hope you would see you can have different number of facilities, the average travel distance, and then how much would you save if you would reposition the facilities. So here you would see in this scenario that we would gain per patient 4.7 kilometer of improvement of travel distance. And it may not look like much. I'll show you why in a second. But when you calculate the whole lot, it comes out to a significant amount. We've also will also be showing a scenario where we're trying to work out what would happen if we would reduce the number of facilities, or if we would add facilities. What would happen? How well would the service be covered in terms of travel distance, and also what number of facilities seems to be the optimal one, where the change would not have any significant impact on improvement of travel distance. And you can see this here in the curve. When it flattens out, starts flattening out at 10 facilities in this particular scenario, that means that if you increase the number of facilities, you're not going to get any significant gain in travel distance saving. And why is travel distance saving also important from the green perspective? If we calculate those 4.7 kilometers that I showed you just a second before in one example, if you calculate this saving per patient, or per visit rather, times 42,000, because this is the number of records for appointments that we have, of taken appointments, then this is the amount of CO2 that you would have saved by not taking such long travel. So now I'm going to show you 3 small videos for you to see how the dashboard functions.
Can we see the current service being offered by PAPWORTH compared to the optimal service for the current patients that would reduce the average travel distance?
Yes, we can, for example, look at the hospital or the patient demand, and we can look at our current facilities, for example, the new PAPWORTH hospital, and we can compare this with the optimal facility distribution, which would look like this, and we can see how the travel distance changes depending on how many optimal facilities we place.
Could you show me what it would look like if we were to rearrange the network based on obstructive sleep apnea risk as opposed to just current patients using the service?
Yes, we can change between different demand scenarios. This will be the risk demand, where we look at the location of patients depending on the risk level. We can also show this risk score on a map. This risk score is calculated from obesity and age, and we can see if we change this to the risk factor demand, facilities are distributed so that the areas with a high risk factor are well serviced.
Leo, can you explain to us what is the difference between different risk maps, please, and how does that help us?
For example, we can compare the distribution of the optimal facilities between the risk factor and the census demand, where the census demand is calculated through the population density. The risk factor is calculated through through the already mentioned risk score containing obesity and age. And we can see that if we change it to the census demand, the location of the facilities slightly changes, so that the areas with high population density are better serviced.
So if I was coming to the dashboard looking to scale back the outreach network and maybe cut 5 clinics out of the current scenario, would you be able to tell me what would be the best 5 clinics to remove to keep accessibility at a high level to patients? And then after that, also the alternative, if I was looking to invest in the network and maybe add 5 facilities, where perhaps the best 5 locations would be to add them.
Okay, let's look first what happens if we reduce the current network of facilities by 5. So currently, with this scenario, we have 27 current facilities, and we can look at what would happen if we redistribute them to 22 facilities. And we can see if we redistribute these facilities to 22, then we get an average weighted travel distance of 11.2 kilometers, which is still far lower than the current weighted travel distance of 18.9 kilometers using 5 more facilities. On the other hand, if we want to see if we want to add new facilities, we can select a conditional P-median scenario, which shows us where to best put our new additional facilities. So we can see if you want to put 1 additional facility for this scenario, it would put it on the bottom left, and it would already reduce the travel distance by more than 2.5 kilometers. And if we add more, we can see the travel distance further decreases, but after some point it doesn't decrease that much anymore.
So this dashboard was produced by the University of Zurich team, to whom we're very grateful also for the demo example. We have a lot more, but obviously this was enough to give you an idea of how you could position facilities versus demand.